thanks so much for the invitation here. I've had the honor of presenting at the Winter Conference in New York last year and then in 2013, I believe. So really appreciate the opportunity to come to this gathering and hopefully share with you some interesting and relevant items for your practice on infectious diseases. As Dr. Kumar pointed out, thank you for 2 hours. We're going to cover a lot of ID topics today. I also want to commend the planning committee because it's neat to get some feedback. And one of the members, at least, wanted some feedback. Yep, sorry.
Just real quick. Dr. Urban's going to be using Polex today. That's one thing I forgot to mention. Please open up your phones. Go to pollex.com. I'll repeat again. That's pollex.com/SMA. Sorry, Dr. Urban.
That's okay, yeah. So one of the members provided some feedback. They wanted some, in this particular talk, I believe, some hepatitis-related information. I loved hearing that, number one. And number two, you'll see where I give you a lot of hepatitis today. So very relevant in the world of travel medicine. So let's get going. Travel's the spice of life for many people. And one of the things that we get involved with, certainly as ID consultants, is the back end of post-travel related complications. I've been spending a little bit of time with some interesting and I think very relevant contemporary cases on that. But we're going to spend most of our time actually on the front end, which is the pre-travel assessment, which is how to prepare the travelers for their departure. Now, we all know people show up for this, especially those of you in primary care, and they say, I'm going on a trip and I'm leaving in 3 or 4 or 5 months, and here's all the information, and I know exactly where I'm going and what I'm going to be doing. Well, if you've dealt with this before, you realize that the usual reality is, when are you leaving? Oh, next week, end of the week, right? And so the key about travel medicine, especially the pre-travel consultation, which is very important to get it right, as I want to share with you today, is all about resources and resource management. So a big dose of what I'm going to share with you today is actually the approach, but also the resources to use to get there. Okay, so let's get going. So you're here at this gathering in Chattanooga, but your partner, unbeknownst to you, just auditioned for The Bachelor, and they won. So they're going to be leaving for Madagascar in 2 weeks. So when you get back on Monday, he asked you for travel advice. So for hepatitis A prevention, what would you give your partner? Would you give immune globulin? Would you give immune globulin plus the Hep A vaccine, the Hep A vaccine alone, or whatever has the biggest needle on it, because you're going to be doing a lot of call now? Go ahead and vote. What would you give for hepatitis A prevention, leaving in 2 weeks? Okay, all right. Okay. You guys are nice. Many groups, it gives you a sense of the folks in the crowd. A lot of Ds. I get a lot of Ds sometimes with different groups. The biggest needle, but you guys are nice. That's good. All right. So Hep A vaccine and immune globulin. Let's talk about this. So Hep A is kind of the forgotten hepatitis virus. Let's face it, it doesn't get the front page of the paper or magazine articles about wonderful new blockbuster drugs. It doesn't get the notoriety of hepatitis B. It doesn't have a chronic form, so it kind of gets shoved off into the corner. But if any of us got hepatitis A, we'd be out at least a month from work, and depending on your underlying medical conditions, could make us quite sick. So individuals with chronic liver disease or immune-compromised hosts, the older we get, the mortality actually increases. So it's a virus to be reckoned with and be respected, even though I think it doesn't get that. Well, shame on us. This study was done a few years ago, looking at travelers leaving for high-risk parts of the world where they could acquire hepatitis A. And you can see the punchline here. 80% at departure gates were not protected against hepatitis A. So shame on us. We can do a lot better job than this. Now, those of you looking at the citation here say, okay, that's old news. We got to be better than this. All right? How about this? A year ago, at our major international infectious disease meetings, this particular study was presented. And you can see that it was an outbreak last year with tourists traveling. They did a lot of things that tourists like to do. And guess what? None of them had received hepatitis A vaccine prior to travel. So it's still an issue that we certainly have and ought to be better at dealing with. Now, where do you need to go to get hepatitis A? Well, you pretty much need to go just anywhere. There are parts of the world in red, a lot of travel destinations that are quite popular that are higher risk than others. But the bottom line is pretty much any travel anywhere in the world. And we know that there's outbreaks in the US at restaurants and there's sporadic cases and so forth. But the bottom line is a lot of popular travel destinations have a very significant risk for hepatitis A. So let's talk about these vaccines. These are, in my opinion, amongst the most wonderful vaccines we have in our armamentarium. So we have two monovalent vaccines, both the Havrix and the Vacta are Hep A monovalent vaccines. They've been around for a while, and we have a good familiarity with them and a good track record. Let me explain a little bit about how they work, because I think this is a point of confusion sometimes. They both are characterized by a primary dose and then a booster 6 or more months later. That booster, the purpose of the booster is to get that vaccine durability. So what happens is when you get that booster, it's not like you need it to be protected at 2 years or 3 years. You're going to run on the primary dose for that. That booster models the vaccine out well over a decade of protection. So it's less important. It's good to stay on task here with that booster, but you don't have to. In other words, if that traveler comes back 2 years later or 3 years later, is it okay to give that booster? You bet it is. And what that does is it gets that vaccine out well over a decade or more of protection. The primary dose is the key for your travelers. And look at these seroconversion rates. They're very, very impressive. After one dose, about 90% will be seropositive at 2 weeks. You can see getting out to a month, just about everybody will be. They're safe. It's an inactivated virus. You can give them with all the other vaccines, and it's just a well-tolerated, terrific vaccine. So good seroconversion early is the hallmark of either one of these preparations. Now, many of you are familiar with the combined vaccine called Twinrix, which combines Hep A and Hep B. And this is a very useful vaccine for travelers. Let me share with you a travel medicine trick that may not be well recognized. But the usual program for the combined vaccine is 0, 1, and 6 months, just like monovalent Hep B. But there's an FDA-approved accelerated schedule for this vaccine right here. So 0, 7 days, 21 to 30 days, and 12 months. Let me give you a quick anecdote. In one of the clinics that I supervise, we have a lot of residents and fellows that are there. So for education purposes, I kind of get the pre-travel consultations to come through this clinic so they get experience, our internal medicine residents, in at least counseling some people for travel. And we had a gentleman show up early this year, actually in the spring, just a delightful man. He's 72 years old, and he was going to take a trip to Thailand in about 4 weeks. And I said, hey, that sounds great. What do you have to assess what people are planning to do. What's your itinerary? What are you going to be doing and experiencing in Thailand? He said, well, I'm going to go visit my girlfriends. Okay, all right. And have you been there before? I sure have, was there last year. And what did you do? I visited my girlfriends. Okay, all right, that sounds fine. Has anybody ever talked to you about hepatitis B? No. Has anybody ever talked to you about HIV? No. So we had a lot of things to talk about. It was a good session. And he, indeed, had never had a discussion about hepatitis B, presumably being sexually active in the part of the world with the highest rates of endemic hepatitis B, leaving in a month. So this accelerated regimen actually is perfect for someone like him. And what this does is it allows you to get a pretty good amount of protection within and your travelers who are not giving you a lot of time to work with, protection against hepatitis B. So that accelerated regimen, a baseline 1 week later and 3 weeks later, basically gives you the equivalent of the first 2 doses of a standard hepatitis B vaccine series. It also gives you the Hep A, right? So the relevance of the accelerated version here is for the Hep B component, but you also get the Hep A along with it. So just keep that in mind when you need to give protection against Hep B in addition to hepatitis A. So the bottom line for Hep A, travel anywhere outside of these regions the CDC recommends to give Hep A. I would argue that travel anywhere warrants hepatitis A. You want to give a dose at least 4 weeks before travel. Now let's get to the heart of the question, which one of the things in travel medicine is there's many shades of gray. So most cases, most questions in travel medicine, you tailor to that individual traveler. And many of you answered immune globulin. And it's not that that's a wrong answer. That's a very reasonable answer. Our traveler, your partner, gave us 2 weeks before leaving. Let's see what the CDC says about this. They say for some groups, older adults, immune compromised, those with chronic liver, chronic medical conditions, it's reasonable to consider. The World Health Organization took the immune globulin out of their recommendations many years ago. So the bottom line is you could certainly give it if you wanted to. However, you'd be perfectly fine giving the Hep A vaccine alone. And the explanation would be, well, if I give you this vaccine by itself, there's about a 90% chance by the time you leave you're going to be seropositive and therefore protected. So it's a good example of the art of this, not necessarily the rigid ruling. So discuss these considerations and options with your traveler, and you can see that this is one of the themes about pre-travel consultation that will develop. But here's what I'd ask you to do. If you have one shot to give as they're running away and getting in their car and going to the airport, make it hepatitis A. So let's talk about the approach to travel vaccines. I call it the 3 R's. And this is what I try to have in mind when I try to sort through them, because they're confusing. There's a lot of vaccines that we could give, and how do we organize them? Well, there's the routine. So what would you be thinking about and doing if they were here for a hypertension check or an annual visit? There's required vaccines, and this really has to do with yellow fever. We'll talk about that. And then any recommended vaccines for unique or special risks that traveler may have. So let's talk a little bit about routine. All of these are part and parcel with adult immunization and routine health care. But the one I want to emphasize is the MMR. I think this one sort of falls off the list sometimes. And the ACIP actually recommends 2 doses of MMR given at least a month apart for any adult without evidence of measles immunity who plans to travel internationally. That could be a pretty big chunk of folks, right? How do we determine the immunity? Well, here are the acceptable, according to the ACIP, methods to do that. So just keep the MMR in mind. At least in my experience, the forecasting tools, some of you may practice where there's a state registry that does a good job, or maybe a not so good job at trying to help you forecast out routine recommendations. So again, not necessarily anything to do with travel medicine. Keep the MMR in mind, especially for your patients who are traveling internationally. Required really speaks to the yellow fever vaccine. And if any of you have traveled to parts of the world, and this is in South America and Africa, at risk for yellow fever, you know it can be a complex consideration. And just to give you an example, remember your partner is going to Madagascar. So the font is small here, let me read it to you, but this is out of the CDC. The requirements for that vaccine, if you go to Madagascar, it's required if you're traveling from a country with a risk of yellow fever transmission and you're more than 9 months of age, including transit more than 12 hours in an airport located in a country with a risk of yellow fever transmission. Can't remember that, right? How are we going to remember that? You can't. So basically, you use the resources I'm going to share with you to get in to specifically look for the yellow fever risk. Because if your traveler goes and has not been vaccinated, doesn't have proof of yellow fever immunization, they're going to be denied entry to that particular country. So this is important to consider. The recommended vaccines are really tailored for your traveler. And we're going to talk about a couple of these, but you see the ones we've mentioned already, and then some other ones depending on the time of year and the destination and the activities that they will be doing. A question often comes up about pre-travel rabies. And of course, individuals who will be working with animals when they get abroad are very important. Remember, there's a wide array of animals that can carry rabies in different parts of the world. And certainly that's a consideration. The way I like to think about it or phrase it, it's really predicated on how easy or not easy will it be for that traveler to get medical care if indeed they are exposed. Adventure bike trips, they're way out there, days and days of terrific cycling out in parts of the world, perhaps where it's not so easy after an exposure to get medical attention and so forth. So that's an example where the pre-travel rabies immunization might be helpful in at least providing some support until they can eventually get their post-exposure prophylaxis completed. Let's talk about one, though, I think that's very, very important. This is typhoid fever. Typhoid fever is alive and well, and a lot of times people have the notion that, well, the risk for typhoid fever is really if you're there in a country for a long time, maybe people who have moved and live there, but really short-term travel has its risks as well. You can see that in this particular study, over a third of the cases of travel-associated typhoid fever occurred in folks who stayed less than a month at the destination. And you can see that about 3/4 of the cases occur in areas of the world that are visited by a lot of travelers, but look at this, only 4% of travelers who had typhoid fever acquisition had a vaccine. So it's an area we need to do better at. The ACIP comes out with provisional updates between their February major updates to the adult immunization schedules. And in 2015, they were busy. There was a lot of them. And one of them was a typhoid fever update. Now, the good news is it really didn't have any new information in terms of a new recommendation or anything we have to be that concerned about. But it's a great review, and it's a contemporary, it's in the MMWR here just last year, a good item to review if you have questions about this vaccine. There's 2 vaccines. They're both about the same in terms of their efficacy. And I want to highlight the dosing or the boosting interval is different between the 2. The polysaccharides every 2 years, the orals every 5 years. Most cases of travel-associated typhoid fever are in the category of folks called VFR, not visual flight rules, but visiting family and relatives. And what happens, and a theme, not only with typhoid fever, but malaria in particular, is that, well, I'm going back to spend time with my folks or my relatives or whatever. I'm not at risk because I grew up there. So VFR is a common phrase in travel medicine, visiting friends and relatives. And the problem is many of these individuals do not seek pre-travel health care because they don't consider themselves at risk. As we leave an area of endemicity for certain infections, we lose whatever protection that we may have had growing up. And typhoid fever is not so much an example of that. It's just an example of these folks could benefit from being protected as well. They account for the majority of cases of travel-associated typhoid fever. So keep that in mind. So where to go for resources? The CDC travel website is excellent. It gets you not only in the ballpark, but it can get the job done for the vast majority of your pre-travel consultative concerns. If you haven't been there for a while, just take a look and explore it. What I do is I bring it up in the room with the patient. And what I like about it, you can see on the left side here, it's for travelers, for clinicians. You put in the country, and there's terrific patient education. So I'll bring it up in front of them, and I'll say, you know, if you got internet access at home, please spend some time on this. Here's some specific areas I want you to look at. Traveler's diarrhea, safe food and beverage, that kind of stuff. Now over here for us, let's put the country in Madagascar and see what it tells us. Gives you this big list. You can't read it from where you're at, but it's basically a listing of the vaccines recommended for the trip to Madagascar. It also comes down here and touches on malaria prevention. Here's yellow fever, for example, typhoid, and the hepatitis up here. Terrific resource, stays updated, and for most of your travelers' needs, it's going to get you where you need to go. It's the go-to resource. Now, many of you probably practice where there's a travel clinic, and if so, there's some commercially available travel websites and so forth that do a wonderful job and are more, much more robust than this. But if you don't have that, this is a good resource right here. The Yellow Book is what the CDC puts out every year for international traveler, and immunize.org is my personal go-to for anything related to immunizations. It's an outstanding resource. Okay, oh, that water looks nice. Let's take a trip somewhere else, huh? So here's your next patient, 33-year-old going on a trip to the Dominican Republic for 2 weeks, but on prior trips she had traveler's diarrhea. So what would you recommend for helping her manage diarrhea on this trip? Pay closer attention to food and water, bismuth subsalicylate prophylaxis plus paying closer attention, antibiotic prophylaxis and pay closer attention, self-therapy using ciprofloxacin plus pay closer attention, or don't worry about it, just have a good trip, be happy. What do you guys think? What would you recommend for helping her manage her diarrhea, travel diarrhea risks during this trip? Okay. Okay, a Couple choices there. Good. Let's take a look. So kind of close to evenly split between those items. Good. So just take a look. This is January in Wisconsin, where I live and so forth. Look at that smile. Look at that water. Look at the palm tree back there, right? I mean, it doesn't get any better than this. This is why we work so we can afford to travel. Well, one bite of that salad and it's all over. It's all over, right? So travel diarrhea, it's not going to kill anybody per se. There's not a mortality. But look at this. At least a third of people after they get an episode, and I bet many of you in this room have had it, or get confined to bed. Your trip gets messed up. 40% change their itinerary. 10% get a poorly understood and very, very concerning element of post-infectious diarrhea, irritable bowel syndrome. This is a high area of investigation that we have very little answers to. But this is a big problem, the persistent diarrhea that can occur by the virtue of the irritable bowel syndrome that can happen. So traveler's diarrhea is important for your traveler because it makes them change what they've been planning to do. A lot of times when we talk about it, people tend to focus on E. coli for good reason. Depending on what part of the world you go to, this is the #1 bug. But the purpose of this slide, and really why I want to talk about today, is it's much more than E. coli. You can see there's some pretty evil customers that show up depending on what you get. Certainly some parasites. Giardia leads the list by far, Cryptosporidium as well. And of course, you don't need to go very far to recognize the norovirus outbreaks in cruise ships, et cetera. Big dose of unknown here, right? And the risk differs between varying where you go and what you do. So let's look at this. This is a terrific review of traveler's diarrhea published last year in JAMA. And what I want to highlight here, here's some bugs, here's different parts of the world. As we get this direction, Latin America and the Caribbean, it's characterized by predominance of E. coli and less drug resistance. However, as we get to South Asia, Southeast Asia, we get more invasive pathogens. Here's Campylobacter, less than 5 to 25 to 35, and more drug resistance. And this is the important implication for management. In fact, look at these scary numbers. Campylobacter-resistant, ciprofloxacin-resistant Campylobacter in Thailand within a very short period of time went from no resistance to 84%. We learned a lot about managing Campylobacter in our military personnel stationed in Thailand, where a lot of what we know and think about traveler's diarrhea came from. So depending on where you go, the key is it's not just about E. coli. There's many other pathogens out there, and Campylobacter is the big one to keep in mind. Now here's another happy guy. I mean, holy cow, just doesn't get any better than this. He's at one of the most famous bars in the Caribbean. It's a beautiful day. He's got something planned here. I don't know what he's going to be doing later. That beer is cold and tastes terrific. Now what piece of advice do all of us get taught, as we're, especially in our youth? What piece of advice? I know you're going to give him more than one piece of advice, but what's the usual advice you would give this guy? What's the best advice about how to avoid getting traveler's diarrhea? What do we always tell people? Don't drink the water. Don't drink the water. Right? Is there any other advice? Watch out for ice. That's right. Yes, sir.
I've read that food should be served piping hot.
Okay, good. So yeah, we all know and we all kind of learn, don't drink the water. Watch out for the ice. For many years, I traveled to, back in several decades ago, to Ixtapa, Zihuatanejo, Mexico. And it's a wonderful, Zihuatanejo is an old fishing village, about a 10-minute taxi between that and Ixtapa, which is a built tourist destination, new hotels and so forth. So there's a constant stream of trucks and taxis and everything going back and forth. We know you walk into a nice hotel, they have those big water coolers when you walk in the lobby. It's the tropics, you're hot, it's, the water tastes great. So one day in Zihuatanejo, off the beaten trail, I was walking around, and the trucks going by carry these big containers, of water. And I saw a truck full of these things in an alley getting filled by a garden hose. So that kind of bummed me out a little bit on those nice water things when you walk in the lobby. In fact, most of the risk for travelers comes from food. Most of the risk. Now, that's not to say that our advice we've all grown up with and taught and thought about ourselves is wrong. There certainly is a risk from water and ice and so forth, but the majority of risk is actually food. So you're right. We're going to talk a little bit about that and how to help our travelers with that. Now, alternatively, for this guy here, we could leave him alone because he's your father-in-law and he's not interested in your advice. He just wants to drink his beer on this beautiful island. That is my father-in-law. And once again, when I see him in a few weeks, I'll get to say, hey, Jerry, I showed your picture during that diarrhea part of my talk again. He loves that when I tell him that. So boil it, peel it, cook it, or forget it. This is the travel medicine sort of moniker, if you will, about how to stay safe from food. So you hit some important topics here. Steaming hot foods, dry bread, peeled fruits. Don't bite through the skin because the organisms are on the skin, right? High sugar content so they don't grow, low pH items, etc. A lot of unsafe stuff. Now, you guys would know the answer to this study, but the meticulous Swiss, in a study done a few years ago, Swiss charter tourists, look at this, 97% made a food faux pas within 72 hours of arrival. In other words, your travelers aren't going to listen to you very well, right? You can give this advice, and you should. And this is one of the areas in the CDC website I point out, but don't hang your hat on it is the bottom line. People travel, and people are going to explore and do what they want to do. So for travelers' diarrhea, there's two main methods to try to help with this. One is an item we should rarely use, which is daily prophylaxis. We'll talk about when we should consider that. For most travelers, it's self-directed therapy. So when to consider daily prophylaxis, critical nature of the trip. I can't afford to miss any time. I got 3 days of meetings, and if I get sick, the business deal's off, and I need to be there, so I need to stay healthy. One of my long-term HIV patients, I've taken care of her since the late 1990s, survived life-threatening cholera-like cryptosporidiosis to the point where she got better, CD4 counts up, she's on antiretrovirals. She came to me one day and said, this is someone whose mortality was off the scale. At her peak stool output from the cryptosporidiosis, she had 31 liters of stool a day. She should have died, and this is how people die of that horrific disease. So a few years go by, she's doing fine, she's healthy, taking her HIV meds, CD4 counts coming up. She said, Dr. Urban, spring break's coming up, and my sister and my cousin and I are going to go to Mexico. And I'm like, oh, I don't want you to go to, I don't want you to go anywhere. You're going to get, you might get sick. Well, you better believe I put her on a daily antibiotic to prevent her from getting sick, immune-compromised hosts, or critical nature or inability to tolerate a diarrheal illness. Very reasonable to consider a daily preventive measure. What if someone's got congestive heart failure? On the best of days, their creatinine is 1.9. Would they be able to tolerate the mild but maybe significant for them dehydration from an episode of traveler's diarrhea? Those are the considerations. So once daily quinolone or rifaximin are some outstanding ways. Now, some of you chose the bismuth subsalicylate, and what I would point out is that's a tough regimen. It's a tough regimen to prevent. It works about 65% of the time, 4 times a day though. So think about your travelers and how good they're going to be at taking something 4 times a day, and what will that bismuth subsalicylate 4 times a day do to them? Black stools, black tongue, and maybe not so appealing there, right? So keep that in mind. So for most travelers, it's going to be self-directed therapy for traveler diarrhea. And this old study was the very first one to show, and the reason I keep this is I think it's neat. This is what a single dose of Cipro does. Right here at 24 hours, so this is 24 hours, percent recovered, 65% from one dose were recovered within 24 hours. So as little as a single dose of a good antibiotic will do the job for a lot of your travelers with traveler diarrhea. More contemporary studies comparing azithromycin with levofloxacin, military personnel, more E. coli than Campylobacter, and this kind of graph, TLUS, is time to last unformed stool. It's kind of a clunky phrase, but what it means is how many hours go by until they have their last unformed stool. And basically, the proportions here are pretty similar, and you can see the timeline, 18, 24, 36 hours. And the bottom line is, many travelers after a single dose will quickly start getting better. Here's traveler's diarrhea in Thailand, and the point of this is to show Campylobacter and how the curves separate if you have, for example, levofloxacin-resistant Campylobacter, right? So in this case, the azithromycin outperformed levofloxacin when Campylobacter was the cause, but you can see for non-Campylobacter, E. coli and others, they perform the same. So this is why it's important to keep that in mind. So the bottom line for self-directed therapy, have people take loperamide. This is a critical part of managing travelers' diarrhea. It works for symptom control. Some people, it'll work just fine. They won't need an antibiotic. But it's good, what I tell people is pick some up or put it in your travel kit before you leave. Now, be careful. This came out just a few months ago, right? The FDA warned about cardiovascular concerns with high-dose Imodium. This sort of came out of the blue. But basically, in the FDA warning, they say here it's approved to help control symptoms of diarrhea. Just don't go over the max approved dose of 8 milligrams per day for over-the-counter use. What's happened is a lot of people were going much beyond that and running into cardiovascular risks, including dysrhythmias. So be careful on that. So you have them pick that up, use it wisely, and then prescribe one of these. Here's how I do. For a lot of travel destinations where E. coli predominates, like in Latin America, the Caribbean, a drug like ciprofloxacin or levofloxacin works just fine. For my travelers going to Southeast Asia in particular, especially if they're going to be there for any stretch of time, I give them azithromycin. This is a wonderful drug to use for travelers' diarrhea. Why? Because it works against not only the E. coli's and others, but also those Campylobacter organisms there. Rifaximin is a terrific drug, 3 times a day, FDA approved for travel medicine for non-invasive E. coli, but how do you know if that's what they're going to get when they get there? It's a little more expensive. So these are the choices, and these are how I write it out for my patients. Now, questions to ponder, or more importantly, what you might get asked, right, from our savvy travelers. Well, here's what I call black box summer for the quinolones, warning about the risks. None of this was specific for travel diarrhea management or prevention, but remember, they told us to not use them for things like sinusitis, acute bronchitis, and UTIs. People are going to hear this. People are going to be aware of fluoroquinolone risks, so we have to be prepared to explain that. Cardiovascular risks, of course, with azithromycin. And here's just a couple studies to give you pause or give you a thought. And these have to do with even the short-term use of antibiotics for travelers' diarrhea. In this particular study, a sort of a scary proportion, about 20% of travelers were colonized with extended-spectrum beta-lactamase producing organisms after a short course of therapy for travelers' diarrhea. Ugh, right? So it increases the risk of colonization. So these are some contemporary questions. It doesn't deter me from recommending management as I've outlined, but keep these concepts in mind. Bottom line, risk assessment, can they afford to get diarrhea? Talk about safe food and drink, but they're not going to follow your recommendations, but make sure they're aware of it. And then self-directed therapy for most travelers. Okay, let's go continue traveling with this famous traveler. For our next case, 52-year-old gentleman is going to Kenya for 3 weeks. He takes lisinopril for hypertension and paroxetine for anxiety and depression. In addition to personal protection measures for malaria, what would you recommend he take? Chloroquine weekly, mefloquine weekly, doxy daily, azithromycin daily, or atovaquone proguanil daily? Go ahead and vote. Going to Kenya for a period of time. Sorry. Okay, a lot of mefloquine. All right. Oh, here we go. A little atovaquone proguanil. All right, good. Oh, like watching a race. There we go. All right, good. We'll talk about this. Good choices. Malaria. Malaria, of course, is alive and well as well. Malaria, Vivax, Oval, Malariae, Nolici can make you very sick, and there's increasing Vivax resistance. But really what we're here to prevent, these guys, but the big one's falciparum. So the problem with falciparum is if you're not immune, in other words, you were not raised in a part of the world where malaria is endemic, you're at risk for the severe forms of malaria, including death and cerebral malaria, massive hemolysis, acute renal failure, et cetera. What distinguishes falciparum from the rest are really 2 things. One is its drug resistance, which drives our malaria choices. The other is how it works. It has some structures on its outer membrane, given the very scientific name knobs, K-N-O-B-S, like doorknobs. And what these are high affinity structures for the endothelial cells in our circulatory system. So the falciparum, as opposed to Vivax and Oval, like to attach to and glom up in those parts of the body where the circulatory system is very unique and precious, i.e. the CNS and the glomerular capillaries. And so that's why we get some of these complications because of that unique pathophysiology. So malaria around the world, the darker shades here show chloroquine-resistant falciparum, and this is the main driver of our drug choices. The lighter shades are some of the parts of the world where there's still chloroquine-susceptible falciparum. And so we have to look at an updated map to understand where our traveler is going and what the risk of drug resistance is going to be. The most drug-resistant malaria in the world are the Thailand border regions. And this is where a lot of the clinical trials are done for new malarial compounds, because this is where multi-drug resistant malaria is. So we have to get an accurate risk assessment. Do they need it? I'll show you an example of our trip to Kenya in a minute, but if you're going to go to Nairobi and stay in the Hyatt and go to the meetings for 3 days, you don't need malaria prevention, okay? But if you're going to go out adventuring, going to go to the rest of that country, you do. So it really is important to understand what they're going to be doing, the time of year, look at the website. But this telephone number is my favorite telephone number in the world. Why? Because you call it, you get a person. You get a human being, and it is the cutting-edge, up-to-date malaria advice, not only pre-travel consultation, but post-travel as well. If you have a case of malaria that you're worried about or managing or whatever, this number is terrific. I've called it many, many times. It's a fabulous resource. One time I called it, and a very delightful gentleman answered the phone, and he had a thick German accent. And he gave me the advice I was seeking on this patient. But he said, "Has anyone ever told you why the most drug-resistant malaria is in Thailand, the border regions?" I said, "No." So I had about a 10-minute dissertation by Hans Lobel, who's a preeminent malaria researcher. And he taught me a lot about why drug-resistant malaria happens in that part of the world. And I had a hard time getting him off the phone. And that's okay. Now, I can't guarantee every time you call this it's going to be an educational event like that, but it's a great practical resource. Mosquito bite protection and chemoprophylaxis, do not underestimate this. DEET, permethrin, and voiding exposure is really, really important. And if you don't do this, you can do all of this you want, and it's going to fail. So mosquito bite prevention is very, very important. How do we pick our medications? Well, if they're going to a part of the world where they're still chloroquine susceptible, chloroquine's a very valid option. It's given weekly. Problem is you got to start it 2 weeks before travel because it's got such a long half-life. You have to build levels and take it for 4 weeks after travel. Why? To maintain levels in case you get late exposure. The hepatic phase comes out to the erythrocyte phase, and that can happen weeks after return. So you need an antimalarial that has levels to combat that late transition if that occurs. Most of the world's chloroquine resistant, and here's the workhorses here. Mefloquine, which many of you picked, which is a very reasonable choice for many travelers. The tovacone proguanil, called Malarone, and doxycycline. Now let's go back to our case. Anybody remember the comorbidities? Psych issues. What's the relevance? Exactly. So one of the concerns is for neuropsych considerations, anxiety, depression, cardiac conduction abnormalities, fine motor skills. Airline pilots don't take mefloquine. You want to stay away from it, right? So the other choices, either tovacone proguanil or doxycycline, would have been a better choice for this gentleman, and that's what I would have recommended. The standard caveat for doxycycline, photosensitivity, and you have to take it daily, which is kind of a hassle compared to weekly. This is a wonderful drug, well tolerated, more expensive. What you do is you pick the drug based on the resistance concerns and then tailor it based on side effects, risk profile, and affordability. Here's Kenya, and this just says all areas, including game parks, under 8,200 feet. But look at this, no risk in the central part of Nairobi. So the devil's in the details in terms of what your traveler is going to be doing. And that's from the CDC website. We don't do a very good job with this. 2001, the malaria deaths reported amongst travelers, you can see that all were given chloroquine, and they went to known chloroquine-resistant areas. So this is a problem. This is old data. That's outdated. Well, look at this. Brand new, the latest data, 2013, the rates of travel malaria are going up. They're going up. Most are falciparum. Most are from Africa. The highest mortality rate since 2001. And look at this. Not many people took it, and not many people took it well, right? So emphasizing the need to adhere to the chemoprophylaxis and choosing it wisely is important. Remember this, when someone comes back with a fever from a malarious part of the world, it's malaria till proven otherwise. This is the list of the bad ones you always need to consider when your traveler comes back with an undifferentiated fever. These will kill your travelers pretty quickly, but the bottom line is it's malaria till proven otherwise, even if they're taking prophylaxis. Why? They may not have taken it correctly. Number two, prophylaxis is not a guarantee for success. All right, that's a nice looking beach. So let's transition to a couple post-travel cases here. This is a guy, I'll never forget this. I was staffing the outpatient internal medicine clinics at our VA hospital in Madison a million years ago. And usually the residents would roll their eyes when I was there, because what am I going to teach them about diabetes and heart failure management? But this day, someone, a very excited resident, came up and said, "Wow, Dr. Urban, I'm really glad you're here today." Oh, okay, maybe this will be good. This gentleman came back from Cuba, had a high peripheral blood eosinophil count. He enjoyed walking barefoot on the beach. He lived with the locals. They all had dogs. And these are the pictures of his foot. This is his left foot, his actual foot. And he had the creeping eruption, cutaneous larva migrans. Here's how it works. This is the hookworm of usually dogs, it could be cats, that finds not a dog and not a cat, it finds us. So the poor hookworm can't complete its life cycle. It stays stuck in the upper dermis because we're the wrong host. The risks are, as you might imagine, being somewhere where this hookworm is, where the dogs or the cats do their duty, so the beach in this example, and either sitting, so that's where the eruptions can occur in the buttocks, or walking on the beach barefoot. And I say, okay, another one of these ID guys showing us this esoteric stuff we're never going to see. All right, here are the top 10 leading dermatoses in series of returning travelers, 1995, 2007, 2008. In these two, the number one travel-associated dermatitis, guess what? Cutaneous larva migrans. So it is relatively common compared to insect bites, skin abscesses, et cetera, a lot of other things here. So be alert for it, be alert for it. It's these linear or serpiginous lesions, and they kind of freak people out because they can see them move. They can watch them move. They move a few millimeters to centimeters a day. And this guy, it didn't bother him too much, but he thought it was kind of fun to watch the thing move around his foot. Very pruritic, and you can get some bullous eruptions too. It appears after return in over half of cases, and that's one of the things I want to highlight with you. And you diagnose it based on how it looks, and it's easy to treat. Now, this particular skin lesion here, I want you to not get confused with cutaneous larva migrans. This particular skin lesion here is what some people in travel medicine called Lyme disease. Lyme disease, this is a phytophotodermatitis reaction from the psoralen compounds in lime. And on the skin with sun exposure can cause cutaneous changes that might look like a tropical dermatosis, but in fact it's not. It's from their margaritas. Here's a student I saw that was a very interesting case. She came in to our emergency department at UW Hospital with a rash and a febrile illness. She had spent about a month in South Africa. She had a nice trip, and she got the right kind of pre-travel assessment. She stayed at a hunting ranch. She did a lot of hiking and so forth, scuba diving, no new sexual contacts. But she's showing up with a rash and a febrile illness. So this is her story. She got a cough, was given Augmentin by a local physician, but then she developed this on her skin. Then she developed more than one. You can see that she had different lesions. These were on her neck and her forearm, and then the fever and chills started. She got a little sicker, came back to Madison, came into the ER. When I saw her, she was afebrile, she was lucid, she had 4 of these eschars. She also had a rash that was diffuse. So, you know, a story that makes us concerned about a variety of things. You can see that her platelet count was a little bit low, and she had a mild transaminitis, okay? So what she had was African tick bite fever. This is the most common travel rickettsial infection. If you look at a world map of travel-associated rickettsial infections, it's unbelievable, the explosion and the new recognition of these organisms in different parts of the world. And it's a very important consideration in your travelers coming back. This particular infection is from a very aggressive tick called cattle ticks. These are not passive ticks. These come out in bunches, which is why many times people have multiple lesions, or why multiple members of a group get the same problem when they're out hiking especially. And they really go after people. the infectivity rate is high, and there's the history that you might get. You get a flu-like illness in the eschars, as I've showed you, and then a variety of systemic illness features. You send the serology, but it's not going to help you. What you need to do is recognize a concern and start them on doxycycline immediately. And basically, in her case, I did that, and within 24 hours, she was better. Remember, we look for a lot of things. Our risks from this kind of travel are pretty daunting. So you bet I looked for malaria, got blood cultures, et cetera. But the bottom line is 2 weeks later, I got the confirmation of what we suspected, the African tick bite fever. Okay, another case, 27-year-old. She unfortunately had to return to Madison for her grandmother's funeral. She had been studying abroad in India, been feeling poorly for 3 weeks, diarrhea, nausea, anorexia, and we had a note, handwritten note from her student health in India. And it had the transaminitis you see here, bilirubin's up. She rarely drinks alcohol, but she does enjoy the local cuisine. Now, when I saw her, this is a few days later after she got back, you can see her transaminitis is increasing, her bili's a little bit higher. Synthetic function looked good. For sake of time, I'm just going to lead you through the serologies because it always takes time to kind of focus on them. But here's the Hep A, IgM negative, IgG positive. What do you guys think that's from? Correct, either a vaccine effect or she may have had previous exposure and cleared it, right? Hep B, core negative, surface antigen negative, surface antibody positive. What does that tell us? Excellent, vaccine, she's protected. Hep C negative, PCR negative, what does that tell us? Never been exposed. HIV negative, that's HIV negative. EBV, CMV negative. The usual things here looked fine, a little bit of hepatomegaly. What do you think she has? Let's not do the poll just for time, just shout it out. Hep E. Why do you say Hep E?
Enjoys the local cuisine. She's got ASTA, she's in the 1,000 range, and she's acutely sick.
And acutely sick. All right. So let's talk about Hep E. This is a neat infection, and we have a lot more to learn about it. If you look at a map, which I'll show you, this thing far outclipses Hepatitis A in terms of causing outbreaks in parts of the world where sanitation and the risk of contaminated food and water supply are much higher. It's amazing. The seral prevalence of this particular hepatitis virus in different parts of the world is stunning. It's off the scale. And there are some associations, as you see here, not only traveler risk, but also exposure to usually raw meat of deer or certain swine and shellfish. And the incubation period and what it does mimics hepatitis A, so it's easy to remember clinically. Here's the board's question when I recertified from my internal medicine boards recently. Pregnancy, look at this. The mortality is highly significant when a pregnant individual, especially in the third trimester, gets this. So it's a very important infection in your pregnant travelers to counsel about. It can form a chronic or transition to a chronic form, but this is an immune-compromised host. And it's something we need to learn more about. But there can be, so that's a distinguishing feature compared to Hep A. This map summarizes a lot of stuff. The punchline, 20 million infections versus 1 million for Hep A, for example, on a worldwide basis. If you look at which countries are endemic, highly endemic in that darker brown here, but look at where we are, and guess what? We're endemic. Seroprevalence studies about 21% in the only large study done several years ago now in the 1990s. So a lot of folks have been exposed, and we're trying to get a handle on what exactly drives that epidemiologic exposure. China's produced a vaccine. We don't have it yet. You make the diagnosis with antibody testing just like the rest, but the FDA hasn't approved any tests, but many commercial labs have it, and that's what you have to do. And it's supportive care, and be careful with immune-compromised hosts because they need some additional vigilance and so forth. So Hep E, good job. Let me wrap up with a couple thoughts on Zika, and we'll answer some questions. This was our Surgeon General in 1970 who was ready to close the book on infectious disease because modern antibiotics, vaccination, and sanitary methods have seemed to have defeated most infectious diseases. Well, infectious diseases are alive and well, and Zika is a good example of it. This is a gentleman coming back from the Dominican Republic with fevers, myalgias, headache, and eye pain. He took his doxycycline. He's pretty sick when you see him, and he's got a rash all over, and you can see that he's got leukopenia, thrombocytopenia, and some transaminitis. And my question for you is, what should you order? And the answer is you order all of these. You look for malaria, even though he took his doxycycline. You get blood cultures to look for his meningococcus and typhoid. You order a rickettsial panel. You got to consider dengue, chikungunya, Zika. So you order all of the above. We're in an era now where telling these three apart you can't do clinically is the bottom line. And when I suggest to people is, if you think of one, and remember, dengue leads the list by far, you think of the other. What I've done for you is I've summarized in a chart form the clinical aspects of these three infections and also the laboratory workup. The approach, though, is really driven by your local health departments. And the reason is you can order dengue serologies and chikungunya, but they hold tight to the Zika. And the reason is the incredible complexity of the Zika serology workup. Why? Because it cross-reacts with dengue tremendously. So you can't just get an answer and look at it. There's a lot of elaborate laboratory analysis that goes into it. This clinical comparison I have for you for a review. Chikungunya is the one that bends up. It's the one that does all the arthralgias, and that's a distinguishing feature. And remember, dengue can cause the shock syndromes. Here's the workup. PCRs and serologies drive our workup. But again, the caveat is over here. With Zika, a lot of cross-reaction. Talks can't keep up. I've tried and I've failed for CME talks. I can't give you the latest on Zika. It changes too much. But what I suggest are three things. Recognize the clinical presentation, know who to call locally, and then use this website when your travelers ask you questions. I bring it up and go through it, especially the concerns about pregnancy. And the CDC put out a response to Zika that actually has these recommendations. We should know the clinical manifestations and be able to counsel travelers is the items I'd like to share with you here. And I'm going to end with this slide just to share with you what we understand about the clinical symptomatology. We're learning, and of course, blood transfusion risk was prominently recognized just a short time ago when the recommendation to screen all the blood products finally came out. Most people are going to be asymptomatic, and about 20% get a mild illness. The Guillain-Barré, which we knew from previous outbreaks, happens, and turn that around. If any of you see someone with Guillain-Barré, please have Zika top of your differential in terms of one of the causes. It usually happens about 3 weeks post-infection. Okay? So there's a few more slides that I'm not going to go over, but what they do is they kind of give you some examples of the complexity of Zika testing and some scenarios about travel. But again, please don't go by necessarily what I put in there because it might be outdated very quickly. Use the CDC Zika website for the latest up-to-date and call your local health department for testing.